This is Dr. Stephen Wang. I am a dermatologist and Mohs surgeon and chair of the dermatology division at the Hoag Memorial Hospital Presbyterian in Newport Beach and Irvine. And I'm also the author of the Beating Melanoma book. And today we have a really, really special guest, Dr. Vernon Sondak, who is the chair of the Department of Cutaneous Oncology at the Moffitt Cancer Center in Tampa, Florida. And Dr. Sondak is one of the luminaries in the field of melanoma surgical oncology. He has published more than 430 articles and 8 books and 82 book chapters.
Thank you. Glad to be here, and thank you for that nice introduction.
We are here today mainly to talk about your latest publication in the JAMA Surgical Oncology that was just published on October 22nd,
Yeah, JAMA
2025.
surgery.
That's right. That's right. So
Mhm.
this is about gene expression profile-based test to predict melanoma sentinel node biopsy, the Merlin study. Now, step back a little bit to for our audience, and
Mhm.
maybe we can talk a little bit about sentinel lymph node biopsy. What's the
Sure.
significance? Why is it needed? And some of the issues that's with this procedure right now.
Okay, great. So, as you well know, melanoma is becoming a really common disease. In your state of Florida, there'll be 11,000 or more new cases of melanoma in 2025. In my state of Florida, we're just behind you at about 10,500. Um, so it's a very common problem. And most of those patients, probably today 85%, present with localized melanoma, meaning you, a dermatologist like you, spots it on the skin, sends it to a surgeon like me, and there's no clinical sign, either by examining the patient or doing an ultrasound or a scan of any sort, blood test, what have you. There's nothing that exists that sees any cancer any place else but on that spot on the skin. However, we know that despite the fact that we can't spot it in any of these conventional ways, a significant proportion of those patients who seem to be localized, the melanoma has already spread to the lymph nodes. That's usually the first place, or through the bloodstream anywhere into the body. Sort of sleeper cells that have escaped from the main melanoma tumor on the skin, made their way through the body's own lymphatic channels, and that lymph node is called the sentinel lymph node. It's the first place that cancer is likely to get to if it escapes from the melanoma. So, I've just been talking about all the great things we learned by and taking that lymph node out. But what we also know is that for all those thousands of melanoma patients that we see today who have localized melanoma, the majority, the large majority, the sentinel node is going to be negative. And so they say to us, oh, I'm really happy, but gee, did we really have to do surgery on my lymph nodes to find that out? Wasn't there any other way we could find that out? And that was the genesis of this study and the technology that we studied. So um, this wasn't my invention or anything that I created, but a company called Skyline DX, working with doctors and surgeons at the Mayo Clinic, created what they call a gene expression profile. They took the biopsies of these localized melanomas, analyzed the genes that the tumor itself was expressing, and then compared those genes, the ones that were up, the ones that were down, to the results of the sentinel node biopsy. And they discovered 8 genes that, when they combined them with just 2 simple factors, the age of the patient and the thickness of that melanoma, they could split the melanomas into low risk or high risk for spreading to the lymph nodes. And that was the first test designed and built from the ground up to make this kind of prediction. And so we asked the question, if we take a couple of thousand melanoma patients who are all having a sentinel node biopsy and ask all of them to donate a little piece of their biopsy that's already been taken and send it free of charge to this company, and don't tell the company what's the story other than their age and their thickness, the two pieces that they needed to know. And we don't know what that test shows, but we know what the lymph node showed. Let's find out if they can really predict. And this was all comers from right from the start, just exactly the way you try to use this test in real life situation.
So just to summarize everything, because you covered a lot of ground, and in essence, that this sentinel lymph biopsy is a great prognostic and staging procedure. And unfortunately, about a large proportion of the patient that will go through the test will have negative lymph node. I think some statistics saying as high as 85%. And now your group went and to conduct this multi-center prospective trial, completely randomized. I think this is the first of its kind that has ever done on gene expression test looking at
It is.
melanomas.
It is the first and largest. It's not randomized. That's not the word we would use
That's
because
true.
we didn't flip a coin. We took, but it's blinded. That's the
Blinded.
operative word. We didn't know what the test result was. The patient didn't know what the test result was. The company didn't know what the node result was. So, and even today, for any individual patient, we still don't know. We only have the aggregate
Gotcha.
information.
No, that's
And
very
the
important.
only other thing I would comment on what you said correctly that it's a large number of people whose lymph nodes are negative. You said unfortunately. Now that's fortunate for the patient that their
That's
node is
true.
negative, but it's unfortunate that we couldn't have figured it out without having to put them through a surgery.
And
Because
that's the whole
in
point about this study. And this study is trying to sort of see which individual maybe that we can forego that lymph node biopsy.
That's right. It was conducted by me and a group of 9 investigators across the country. The testing was paid for by Skyline, and each center, the costs of the trial were paid by Skyline. Yep. So they are considered the sponsor of the trial, but were blinded from to the results until we had them to publish and present at scientific meetings and publish in this journal.
All right. Why don't we jump into the results? That's probably what the most exciting part of the whole thing is.
You had to have the gene test, and you had to have the sentinel node so we could compare the two. That's where the 1761 come from. The T1 through T3 means localized melanoma, clinically localized and no thicker than 4 millimeters thick. We thought if it was over 4 millimeters, those patients were at such high risk, there was no possibility of any test saying, oh, you don't need a sentinel node biopsy. But in the earlier stages, the earlier T stages, 83% of the people who had a sentinel node was negative. Therefore, roughly 17% were positive, actually 17.6%. And that blue square is right on the 17.6 line. So that's the starting point. If we did the sentinel node to everybody, and in this study we did, 83% would be negative, 17 would be positive. And that's not bad. That's more than enough. So 7 or 24, if you know your risk status using this test, 17.6 if you took all comers. This is clearly biologically solid information. Statistically, any way you want to look at it, a low risk and a high risk, there's a difference. Now, if we move over to the left-hand side, we do more by the thickness of the melanoma. And we might say T1B. What's T1B mean? T1B is 0.8 millimeters thick to 1.0 millimeters thick. T2 is 1.0 to 2.0, and we can group those together. If we take the T1Bs and the T2As, we go over to the right, and that's clinical stage 1B. And I like to focus on that because that's a big group. That's over 1,100 patients. They have a slightly lower risk, only a 12.5, which means now if you're a clinical stage 1B and you just say, I just want the sentinel node biopsy, great. We would do it. It's within the guidelines, but 87.5% of the time, you're going to have a negative test. If we use this test and we know nothing else but that you're stage 1B, a high risk moves over to the other side of that straight line at 18.3%. A low risk moves solidly into that gray zone of 6.5%. Is 6.5 enough to do the sentinel node biopsy? In many cases, it is. In some cases, it isn't. We don't show it here, but you can then just put your thinking cap on and say, what if I'm low risk, stage 1B, and 65 or 67 years old? Won't it move over even a little further? Yeah, just a tiny bit. They're pretty closely aligned, might even move over to 6.1 or 2, something like that. And we can begin to give you an individual estimate that's not based on some calculator, somebody's guessing, somebody took a handful of cases and tried to plot where you are. This is based on exact knowledge of 1,100 patients in your exact clinical stage who had the exact same test, and here's what it came up with. And now we can have an informed conversation.
So it seems to me that this test will become super valuable for stage 1B patients. And it turns out I think that's a majority of the patient that we have, and because most of melanoma we do catch it relatively early. But maybe we can shift gears a little bit and talking about, let's say, the T1As. This is a very, very important, right? Because if you just look at the table to say T1A, you think this is something that is a less than zero point 0.8 millimeters, no ulceration. But what you're really telling us, this is not the typical T1A group of
No,
patient. So that is actually very, very important. But that's really good to know.
and it was a super selected group. But when we apply the test, look what happened. 80% were low risk. And in our study, not one of the low risk patients had a positive sentinel node. So they were adverse by the textbook, low risk by the test, zero positive nodes. And if they were high risk by the test, it was only 20% or so that were 16% that were high risk by the test and adverse. That combination got you above 20% chance of having a positive note. So these are people who might have been told, you don't need it, but maybe they do need it. Now, we're excited about this observation. Definitely feel that T1A patients without some other guiding factor, they shouldn't have a sentinel node biopsy. That the adverse features we thought said do surgery on them weren't good enough. This test might have a use in those people in finding a few of the needles in the haystack that are being missed by the conventional wisdom.
So, Dr. Sondak, that was a very, very important point. I think stated differently, I mean, I think your observation also explained another phenomenon that we know that 3 to 5% of thin melanoma, that is tumor thickness less than 1 millimeter, can actually develop metastatic disease. And but even though it's 3 to 5%, but majority of the melanomas are thin, that subgroup actually represents 20 to 30% of melanoma death. So those were
Mhm.
some of the data right there. So what you're describing is probably just another, the test is actually uncover a lot of biological phenomenon that we don't currently have the traditional current standard just not able to uncover that high risk population.
No two people are different, or no two people are different. No two people are alike. Every
Yeah.
person's different. Every melanoma is different,
Yep.
and where it's located, and what surgery would be needed. Now, if I've got a stage 1B, now I start looking at all the other things. Where is it on their body?
Yep.
What type of melanoma is it? What about the other factors like the mitotic rate? It was really exciting to us to see that even though the mitotic rate is well known to be a powerful additional factor, it this test still gives you more information, even if you know the mitotic rate. If the
Yep.
mitotic rate is low, high risk is still worse than low risk. If the mitotic rate is medium, high, still gives you some information. But we can start putting a whole picture together and say, you're older, you got a few things that are are
How,
not perfect, and maybe this will be a harder surgery in you. You're younger, this one's a slam dunk. You want to know what this sentinel node shows. Now, maybe you're somebody who says, I don't want surgery. I don't want this. This doesn't sound. But now you say, oh boy, but I've got a 30% chance here of having a positive node. Maybe that's too much for me to pass up. So, as I said, is nothing is black and white. Sometimes we look that every coin has two sides. It's not only about predicting who shouldn't have it. Every once in a while, we might want to use a test to predict who should have it to help convince somebody.
I
The
know the
great,
study has two main objectives. We cover a lot talking about the primary objective,
Mhm.
everything we talked about, because there's also a secondary objective, right?
You're exactly right. And that's a great point. We're excited about this information. This is the primary goal of the study to look at how it predicted sentinel node. But you could imagine, right? We already said that even if you're high risk, you have a 75% chance of having a negative node. But maybe that high risk, meaning the high risk result means that you also have a higher risk of the melanoma showing up somewhere beside the sentinel node. Or maybe the test sometimes will pick out those few people where the sentinel node was missed and it shows up later on in a different lymph node. Um, so we're committed, along with the sponsor, with Skyline, we've committed to continue to follow these patients. And they've agreed as part of the study, they got the test for free and they got the care, standard of care treatment, and nothing about their treatment was changed. But they've committed as patients and study participants to continue to check in with us once or twice a year. How are you doing? Has the melanoma come back? And over the next couple of years, we're going to be analyzing that data and just asking the question, what else can this high risk, low risk result tell us? Um, and so I think within the next 2 years, we'll have some information that allows us to say, again, no two patients are alike, but we can't discriminate them right now. All your nodes were negative on the sentinel node biopsy, but your test was high risk or your test was low risk. You would think just intuitively, boy, there must be some difference between those two melanomas that caused the test result to be different, that must have some meaning. Maybe it's minor, Maybe it's just a percentage point or two, and it's not enough to change anybody's decision making. Maybe it's some useful information that just like this will uncover by studying it and only by continuing to follow the data and going where they lead, not just assuming that we know the answer.
I mean, I think this is also a very important tool that we have in the armamentarium to discriminate, to differentiate, and to further subclassify the patient population and figure out like what we need to do. This is like a incremental step towards personalization of
It, it,
treatment and
it's
diagnosis.
a
Yeah.
definite step, and its value is enhanced because we have so many people,
Yeah, yeah. I
1,761
mean
people, and
that
so much granular detail about those people. And so we don't want to forget to thank all of the patients who volunteered to participate in this study.
I completely agree with you, and we really have to thank this group cohorts of patients and everything what you've just mentioned. And I think on that note, I want to thank you for your time, and I want to thank you and your colleagues for putting together this really well thought out experiment. But much more importantly, I think the infrastructure, the patient subjects that you have set up, you will yield a lot more valuable insight about how we should be taking care of patient, and especially understanding the melanoma biology a lot better than we understand right now at this moment.
I'm delighted and thank you for the opportunity to talk about this exciting study.